proceed to
Good morning.
Good morning, Duke.
Good morning.
How are you? I'm sorry about the ungodly hour.
It's all right, but with apologies, I might sign off after my talk. And
No, that's absolutely fine, Duke. I completely understand. The UK is in a bit of a bind this morning. Everyone's panic buying petrol.
Oh, is that right? What's happening?
Well, there's a problem with supply chain because of drivers, and so everybody has gone crazy and started panic buying petrol.
Oh my! Well, that's interesting.
So that's what I've been doing this morning.
We got an extension. Yeah, there was another one.
How are things over in the States, Duke?
We're doing all right. It's you know, actually, I like to think I live up in the same corner of the country where most people are vaccinated and kind of are still wearing masks voluntarily. So we're doing well. Thank you.
Yeah, we've got a lot of that over here. You know, I think there's still quite a lot of people wearing masks, especially in the crowded areas.
Is Malcolm going to be on the call? I'm trying to figure out what his time is. He's probably about 2 in the afternoon, maybe.
I think it's better for Malcolm.
Yeah.
I felt guilty because last year Malcolm was in the middle of the night.
I remember.
And now I put you in the middle of the night instead. It's a no-win situation.
Well, it's all right. I'm happy to share the pain. And he certainly had a tough time in Hong Kong with COVID. They're still pretty strict.
And what about the hospitals? How are they?
We're fine. There are not many COVID patients here. You know, other parts of the country, they're overwhelmed and all their ICUs are filled with COVID patients. But it's a very small number. What I would say is that we are full with other patients with non-COVID problems. A lot of our regional hospitals have lost staff for one reason or another. They're burnout or illness. So we're, at least in cardiac surgery, our volumes are up because we're taking these cases that the other hospitals cannot do. Unfortunately, we've been able to handle it, but the hospital is constantly full, and you know, one worries at what point our team will get burned out as well. But no, we're doing well.
Yeah, I mean, we've got exactly the same problem. We have very few COVID cases in the hospital, but the problem is burnout of ITU staff.
Yeah.
And so we're struggling, and of course, and there's a huge load of people who are now coming into the hospital for treatment, and the emergency departments are rammed. And there's been a lot of burnout amongst the ITU staff, which has been a real issue for us.
Yeah.
Malcolm is joining us.
Good afternoon, Malcolm.
Hello.
There he is.
Hi, Malcolm.
Good morning. Good afternoon.
Good morning, Duke. How are you?
Good, thank you. Good to see you.
And you, sir. Very much so.
I was wondering if you might be making the trip back to the UK for this, but I guess that wasn't meant to be. When was the last time you were in the UK?
No, I can get into the UK, but I can't get back into Hong Kong.
That's what I've heard.
We're still
our friends
3 weeks quarantine for us still.
Our friends Seal and Ron Tan, who you met in Nepal, have come over to the States for a while and had to hurry right back. And your quarantine restrictions are still draconian. Incredible.
Yeah,
Good
absolutely.
morning,
Debbie.
Morning.
Well, they're sort of going for 0 cases.
You.
Hi, Debbie.
Sorry.
Morning. Oh, actually, what time is it
Morning.
there? You must be.
No, 3 o'clock in the afternoon.
Oh, right, you're okay.
I've been kind to Malcolm and bad to Duke.
Yes, yeah. It must be really
Yes.
in the middle of the night
It
in
was
the
3
US.
o'clock in the morning.
Don't say I feel bad.
Oh dear.
Yeah, you're well into the afternoon, Malcolm. Is that a beer on your desk? How many people have signed up for the course this year?
We got 120,
Wonderful.
which is fantastic.
And do you have any idea of how many people are watching via CTSNet?
There were, I know for the last streams on Thursday, one of them hit at least 1,400.
Wow.
And considering, I guess it's mainly an American market with it, considering the time difference. I thought that was pretty good for live stream. I guess there'll be some Far East there as well, but I thought 1,400 was reasonable.
Yeah, that's fantastic. With my CTSNet hat, I've seen how our webinars have really been popular this last year. Regardless of what countries, how they were dealing with COVID or how prevalent the disease was, they were just, people are so hungry to go to meetings or at least, learn. It's been a wonderful platform, I think, and I can also say CTSNet is just really happy to be part of this course and helping share the wealth with other parts of the world.
I mean, I think it's great. It's great for the course, and I hope it works. Speaking to Graham, I think it works mutually for CTSNet as well. So I think that's good for everyone.
Yeah, 1,400 is a very good audience. Not that it matters, but what's the weather there?
The weather is meant to be good this weekend. I think it's going to be a little bit overcast, but it's going to be about 20 degrees Celsius.
Thank you. I have trouble with the math at this time of the day.
Yeah. So it looks like it might be a nice weekend. How are things in Liverpool, Debbie? You all right?
Yeah, okay, thanks. Yeah, busy again. Yeah, looks overcast, but yeah, warm here.
Warm.
Yeah, we're okay. How's it down in Birmingham?
It's all right. There's no petrol.
Oh, really? Yeah, I heard about that yesterday.
Everyone's queuing everywhere.
Yeah, yeah.
Luckily
That's
for
the
me,
latest.
luckily for me, they haven't twigged on around the Heartlands area, so I managed to find somewhere
Oh my goodness.
on my way in. So
Oh dear. So you're actually physically at Heartlands, are you?
yeah,
Okay. So how many of you are there?
not many. There's myself, Clive, and Lorraine,
Okay.
and then the thoracic guys will come in later. So
Okay.
we've
I've just sent Lorraine my slides just in case, but hopefully
Okay.
it'll be all right.
Has the IT part of the meeting gone smoothly?
Oh.
No Zoom problems the last few days?
No, it's been okay. We've had a couple of I think everyone's just got used to it, haven't they? I think we've had a couple of internet dropouts, which there's not an awful lot you can do about, but otherwise I think it's been pretty good. So Malcolm, are you happy to run the cases? Oh, where's he gone?
Yeah, he's gone under his table.
He's got to find another beer.
Yeah, I was going to say you got a little refrigerator under the desk. That's clever.
I've the internet's not stable enough in the study, so I've had to revert to the living room.
Okay.
So my wife will be joining us in about half an hour.
At last, we'll get some sensible opinion.
Indeed.
Yeah. So Matt, I was saying, you happy to run the cases?
Yes. Yes.
So I think you've got Eshan doing something relatively simple, which is a cannulation type strategy, type A. Debbie, I think you're doing something.
I've got a couple of videos of arch cases.
Yeah.
They're both redos. They're both type A dissections coming back for redo surgery. One's an acute one and one's a chronic one.
Okay. Do you want to do the acute one?
Okay.
Redmond.
It's just around cerebral protection, I suppose.
Yeah,
really. I haven't got any other slides. I've just got, but we can just talk through the cases basically.
No, that's okay. If it's around cerebral protection, do the chronic one.
Okay.
Mark is going to do, if he manages to join us from France, is going to do a redo case. So I did ask him to talk about sternal re-entry and all that kind of stuff. And George has got a particularly nasty Jehovah's Witness case.
Oh dear.
Yeah. So if he's finished transplanting, which I'm hoping he has.
Oh.
He should have done. He started early enough last night.
If you're ready to go, I'm going to start with
Yeah. Okay. So I'm gonna we're gonna admit people, and then we'll start. Okay, good morning, everybody. Welcome to day 3 of the Birmingham Review course. The first session is aortic surgery, which has always been a big hit. I'm grateful to CTSNet for live streaming this as well. And it's lovely to have, I'd like to say, old friends back with us, if not in person, in spirit. So first of all, we've got Professor Duke Cameron, who is a stalwart of the review course, and he's going to talk to us about aortopathies. And once more, my apologies to Duke for the ungodly hour which I've woken him up at. Debbie Harrington, who's a consultant aortic surgeon in Liverpool, will talk give us a guideline update for aortic surgery. And then Mr. Pedro Casrino from Los Angeles, morning Pedro, evening, is going to talk to us with dealing with aortic arch, and he's going to talk to us about the different techniques which are now available, open, hybrid, endovascular. Following that, we're going to have some case discussion chaired by an even greater stalwart of the review course, Professor Underwood, joining us all the way from Hong Kong. And we've also got local faculty, Mr. Eshen Senanaika, George Mascaro, and Professor Redmond will be joining us from Ireland. So without further ado, we'll start. Thank you very much, Duke. Look forward to hearing your talk.
Thank you. Just need to get permission to share my screen. I think you've disabled the screen.
It should be good to go now, Duke, for you.
Yes, thank you. Apologize, I wish there was a way to have this ready. I do apologize. There we are. I do apologize, but thank you again for the invitation to participate in this course, which is always a highlight of the year for me. I've been asked to talk about aortopathies, one of my favorite topics. And as in previous years, I would like to offer that if you send me an email to this address, ddcameron@partners.org, just put BRC 2021 in the subject line, and I'll send you a copy of this presentation, a PowerPoint. I'll also send a set of references that I use to put the talk together. And I'll show this slide again at the very end if you don't have the time or utensils to write this down. Many of you know this is one of my favorite quotes related to diseases of the aorta from Sir William Osler. There is no disease more conducive to clinical humility than aneurysm of the aorta. One knows that Osler is truly one of the great thinkers in Western medicine, so much so that 4 institutions claimed Osler belonged to their own, McGill University in Canada, Johns Hopkins, and the University of Pennsylvania in the US, and finally Oxford. I also draw inspiration from a more modern philosopher, Elton John, and I'm reminded every time I try to talk about things like genetics that, like the Rocket Man in 1972, he said, "All the science I don't understand, it's just my job 5 days a week." Well, aortopathy is actually a very general term, and it's probably more valuable to talk about some of the specific conditions in which aortopathy is very prominent. And I've listed them here: bicuspid aortic valve, Marfan syndrome, Lowe's-Dietz syndrome, Turner syndrome, Ehlers-Danlos, familial thoracic aneurysm syndrome, various forms of congenital heart disease in which late aneurysm is a component, and then lastly, inflammatory diseases like Takayasu's. I'm going to try to touch very briefly on each of these. Obviously, this is a rapid stroll through a vast field and also field where things are changing rapidly. I will not say anything about the inflammatory diseases. John Eleftheriadis likes to point out that diseases of the ascending aorta are actually quite different from those of the descending aorta. And much of what we're talking about here are largely processes that affect the ascending aorta. At that dividing line between the proximal aorta and descending aorta, we see that the ascending aorta tends to be involved in younger patients, often with root or ascending aortic aneurysms, that the proximal aorta is rarely ulcerated or atherosclerotic. These are dilated and thinned aorta. There is a strong component of heritability and a genetic basis for many of these. One rarely sees calcification or thrombus or debris, and really atherosclerosis is really seen mainly only in much older patients. And the descending on the aorta is more of a degenerative disease site, much more atherosclerosis. One sees ulceration, calcification, thrombus, and embolic debris. And it's interesting that so many of the genetically based diseases affect primarily the proximal aorta. And although this is not a hard, fast rule, I'm fascinated that in the proximal aorta, aneurysms tend to develop first and then dissect, whereas in these younger patients, dissections actually involve the descending aorta first, and then there's late aneurysm. And so aneurysm frequently leads to dissection, but in the descending aorta, where there are more degenerative processes, aneurysm actually leads later to dissection. So there are some other terms that I won't go into because there's so many that people apply to these processes: syndromic, genetic, familial, hereditary, connective tissue disorders. That's the one that I in particular don't understand, because virtually all of these diseases that I mentioned are connective tissue disorders of one sort. And what is it if it's present genetically from birth, but really doesn't manifest later? Do we really call those genetic diseases? So I'll try to avoid those particular terms. All of you are familiar with the bicuspid aortic valve aortopathy, and by far, this is the most common cause of aortopathy, given that 1% to 2% of the population have bicuspid valves. More than half have some ascending aortic dilatation. These aortas, once they dilate, tend to dilate faster than other tri-leaflet valves. Their rupture risk, size for size, is about the same as with tri-leaflet diseases, except when there is aortic stenosis or coarctation. And keep in mind, too, that there are more patients with bicuspid aortic valve than all other patients with congenital heart disease combined. More patients with BAV than all congenital heart patients combined. So this is really by far the most common cause of aortopathy. It's interesting that for many years, the most common theory of the dilatation of the aorta associated with bicuspid valve were hemodynamic theories, that the eccentric flow from a bicuspid valve exerted pressure on the aortic wall. But then in the 1990s in particular, there was more focus on the intrinsic properties of the aortic wall, and a lot of demonstration that there is an intrinsic aortopathy independent of the hemodynamic effects of a bicuspid valve. But I think we've settled in some middle ground where we appreciate that both are important, that the stage is set by some genetic basis for the aortopathy, but this is modified by abnormal flow patterns. And much of this does account for the different morphologies of the dilated aorta that one sees with a bicuspid valve. The morphology is diverse, but it is by and large limited to the proximal aorta and the arch, mainly proximal arch. And very unusual to have significant aortic disease beyond the left subclavian. As best we can tell, the determination of aortopathy is genetic, but there's been no single gene identified responsible for bicuspid aortic valve which is remarkable given all of the incredible work being done right now to understand the genetic basis of disease. Let's move to the poster child of aortopathy, and that is the Marfan syndrome. And of course, the reason that so much more is known about Marfan syndrome is that it's a phenotypically obvious disease. These are people one can identify on the street, tall, lanky, the arachnodactyly. They're all by the time they're adults are wearing eyeglasses because of the dislocated lenses. And although these are not common diseases, it's 1 in 10,000 people, it is a major source of significant surgical aortic disease. The cardinal features, of course, are the skeletal that I've mentioned, the ocular, which is the most constant, the dislocated lens, and most importantly for survival, the cardiovascular systems, and all of the premature mortality due to Marfan syndrome is from aortic catastrophe. Without a diagnosis and without treatment, on average, lifespan is shortened by about 1/3, and this is due to aortic aneurysm and dissection. These aneurysms are interesting. They are, by and large, limited mainly to the root. The sinuses of Valsalva are quite dilated. The ascending aorta tends to taper down to normal diameter, as is the arch. It's unusual for the descending aorta to dilate in the absence of dissection. And here, of course, is the intraoperative appearance that you all recognize. So I'm fascinated, of course, that although we focus on the size of the root and use that as the trigger for surgery, the tear and the dissection rarely occurs in the root itself, but rather just above it, just in this area here above the sinotubular junction. So I regard the root size as a surrogate, or as a marker for aortic fragility, but it's not actually where the rupture occurs. I find that a comforting thought when one's trying to obsess about a few small millimeters in determining what is the right threshold for surgery. If one knows that this is really just a surrogate for fragility rather than the actual site of the catastrophe, allows one to think of maybe a little more rationally about time to intervene. The valve is often competent, even when the root is quite dilated. Rupture and dissection are rare before the age of 12, but it is the most common cause of death in Marfan syndrome, premature death. And the indications for surgery, I'm not going to include these in the talk because Deborah, our next speaker, will cover these. Some caveats is that the surgery should include replacement of the sinuses. Prophylactic arch replacement is not necessary in the absence of dissection because the need for interventions later is very low. Bentols give great results. The reimplantation valve-sparing root provides better annulus stabilization than a remodeling, and that's particularly important in this disease. Lowe-Dietz syndrome is a relatively new aneurysm syndrome. It was described in 2005 at Johns Hopkins. Bart Lowe was a Belgian geneticist who worked with Hal Dietz, our pediatric cardiologist, and they saw a number of children who were referred in for query Marfan syndrome, and they clearly had something different. The principal features of this disease were the hypertelorism, this arterial tortuosity, particularly in the thoracic aorta and its proximal branches, which are very unusual in Marfan syndrome. In the absence of dissection. So, and then this nearly constant feature of a bifid uvula. So if you see a strange young person with wide set eyes, arterial tortuosity, and a bifid uvula, you've made your diagnosis of Lowe-Dietz syndrome. And unlike Marfan syndrome, where the mutation is that of fibrillin, this disease is usually due to mutations in the TGF-beta receptors. It leads to excess TGF-beta signaling, and for that reason, same type of aneurysms that Marfan syndrome has, but the TGF-beta excess is because of a mutation in the receptors rather than a mutation in fibrillin, which in turn affects TGF-beta signaling. The natural history of Lowe-Dietz is much worse than Marfan syndrome. This is the initial group of 90 patients that were seen at Hopkins, a mean age death of 26, mean age of surgery at 18, mean age at first dissection at 25. This is all 10 years earlier than Marfan syndrome patients. In pregnant women, it was particularly lethal, with 2/3 of pregnant women having life-threatening events, either uterine or aortic rupture. The most common causes of death still are thoracic aortic dissection. The surgical approach is very similar to Marfan syndrome. It's usually prophylactic replacement of the root and ascending aorta, but the intervention is done earlier in life and at smaller diameters. These were some of the early guidelines, and I would say that these thresholds have been modified a little bit as we've learned that there's more heterogeneity in the severity of this disease, and we're trying to tailor this a little bit more. Unlike Marfan syndrome, there's a lot of disease in the peripheral branches, subclavian arteries, axillary arteries, and carotids in the absence of dissection. And they require very thorough imaging and very close surveillance and continued monitoring. Turner syndrome is a genetic disorder that all of you will recognize. And it's been long known that bicuspid aortic valve and coarctation are part of this syndrome. Half of the patients will have a bicuspid valve. And their aortic fragility has also been appreciated in a higher incidence of dissection in somewhat smaller aortas. And this plot here shows the ascending aortic diameter in a group of patients followed at the NIH. And the 3 circled dots at the top were those who had dissections. And you can see that although they tended to be the larger aortas in this group of patients, but they were all less than 5 centimeters. And the point of this slide is that this is a small stature group of patients who are at risk for dissection. And this is the only group that I believe there is truly good data to show that we should index the threshold based on body surface area. There is a formula at the bottom there, which can be used to identify those patients that are at high risk. The absolute diameter of the aorta probably isn't the best indicator in this particular disease. Ehlers-Danlos, particularly the type 4 vascular disease, is due to an abnormal collagen. These patients have the joint hypermobility, skin hyperelasticity. It's a much less common disease than Marfan syndrome, but with a similarly depressed life expectancy. And 80% of patients have major vascular complications. And the important take-home message here is that aortic or vascular rupture can occur at any diameter, and that aneurysms are frequently absent. There is still a high incidence of complications from surgery, anastomotic problems, and bleeding. So traditionally, one has been reactive here rather than prophylactic in addressing vascular catastrophe here. But that may change as surgical strategies improve. This slide is just to show that the thoracic aorta is still the major site of aortic problems in Ehlers-Danlos syndrome. Familial thoracic aortic syndrome are those thoracic aneurysms that are obviously hereditary and that they, within a family, affect primarily first and second order relatives. There is no characteristic phenotype. This is probably the one aneurysm syndrome that is perhaps hardest to recognize. They make up about 20% of all thoracic aneurysms, and several gene mutations have been identified. And I won't say much more about these, but this is actually a large group of patients, but the one that is less well characterized than most. And in fact, the primary identifying feature here is the lack of a distinct phenotype and the strong family presentation. I could talk for an hour about congenital heart disease and how it presents patients with aneurysms. And these these congenital heart defects are mainly those of so-called conal truncal defects, tetralogy Fallot, truncus, double outlet right ventricle, and transposition. Even hypoplastic left heart syndrome could be included. Virtually all of these patients have abnormal aortas at birth, and either late after repair, late after presentation, their aortas may progress and dilate to more than 5 centimeters and present sometimes with very unusual morphologies. That top slide is a Norwood that had his ascending aorta reconstructed and now has a monstrous dilatation of the ascending aorta. Some of that is patch, some of that is aorta, and sometimes it's hard to tell which is which. And there's not a lot in the way of guidelines about when to intervene, but I can tell you in general, these aneurysms associated with congenital heart repairs, and indeed even the Ross procedures, have, we believe, a somewhat lower risk for rupture and dissection, and that in general, these patients, I think, can be safely monitored until the aorta is closer to 6 centimeters, unless, of course, the aortic valve or an RVPA conduit needs intervention, in which case timing surgery might be earlier. This slide is just a nod to some of the fascinating work that's been done on the pathophysiology of aneurysms as it relates to this TGF-beta signaling. Back in the earlier days when we began to understand why the Marfan aorta dilated, the focus was on fibrillin, and the thought was that fibrillin was a structural protein that was abnormal because of the mutation on chromosome 15. And we were quite content with that until someone asked the very important question, well, if it's just a structural protein, why is there bony overgrowth and long fingers and tall stature? You don't get that from a defect in structural protein. And it was asking that question and looking harder as to whether or not this broken fibrillin might actually be doing something else, that it might actually be affecting cell growth, cell regulation, and growth itself. I won't tell this whole story, but I encourage you to read it in some of the references that I've included. But the recognition that fibrillin is not only a structural protein, but it's a regulatory protein. And because it's abnormal, it has interfered with TGF-beta, which is probably the most important cytokine in the regulation of tissues involved in the aorta and cardiovascular system. And that it's the excess of TGF-beta that leads to aneurysm formation. And it was fortuitous that in looking for established drugs which might lead to TGF-beta blockade, that one might mitigate this process. Losartan was simply an antihypertensive that was already known to affect TGF-beta signaling. And it was then introduced in trials to see if it could modify the course of aneurysms. And in general, certainly in the animal models, it worked well, less well in people, but it has certainly become a mainstay in the pharmacologic management of aneurysms, in addition to beta blockers. But it's a remarkable story of modern science and how thinking about processes and exploring unconventional avenues of research has been remarkably productive. I'm going to finish just by saying briefly on the issue of genetic testing in aortic disease. The most common genes that have been identified in the development of aneurysms are these that you've seen here: the fibrillin, the TGF-beta receptors, the ACTA2, the MYH11, and SMAD genes. The panels that are often done and are commercially available examine these and other genes, about 20 of them. Their value is in confirming the diagnosis and perhaps modifying the threshold for intervention once you've confirmed this, and also making the diagnoses in phenotypically less obvious family members, and therefore can be important for genetic counseling. These figures here for the panel and the cost of complete exome analyses are probably out of date these days. In the US, insurance coverage is quite variable. And this is still it's valuable, but its role in the management of these patients is still evolving. This is just a slide which I know is probably too hard to read here, but it does make some distinction between the syndromic, the phenotypically obvious aneurysm syndromes, and the non-syndromic ones, and the kinds of genetic mutations that are currently part of these panels. Dr. Eleftheriadis at Yale has written a very nice paper looking at his experience in using routine genetic testing. And he's shown that when one screens all comers, only about 25% of aneurysm patients had recognizable mutations. And much of this, I'm sure, is that we just haven't identified all the mutations yet that are important to aneurysm development. And my last slide here is just to remind you to be aware of the issue of the fluoroquinolone antibiotics and their effect on aortopathies. This was an interesting observation that arose from the orthopedic world, where a number of spontaneous tendon ruptures were seen in patients who had been on fluoroquinolones for relatively short time, just a few weeks, and then a focused look at whether or not aneurysm patients might also be suffering the same side effect. And a recent meta-analysis of studies on looking at this in aneurysm patients, which are included in that email, which I can return to you, shown that the risk of significant aneurysm enlargement or rupture is doubled within 60 days of institution of these antibiotics. It's more likely to occur with oral than IV administration, probably because oral administration is associated with much longer term use. The mechanism is unclear, but is thought to relate to increased matrix metalloproteinase activity that has been demonstrated from this class of antibiotics. And importantly, that risk of aortic catastrophe regresses with cessation of the antibiotics. But this is an important thing to keep in mind when prescribing antibiotics in patients with aortic aneurysms. So again, I want to thank you for the privilege of speaking to you and being part of this remarkable annual conference. And I look forward to next year when hopefully this will be not only virtual, but also an in-person visit and a chance to meet the colleagues and friends whose relationship I've enjoyed with for at this point a very, very long time. So thank you again. Take note of that email address and just put BRC 2021 in the subject line. And I'm happy to share all of this information, and as well as a couple of PowerPoints on related topics. Thank you very much.
Duke, thank you very much for that overview of a very difficult topic, I think. I just asked the delegates, if you've got questions for Professor Cameron, please ask them now, because Professor Cameron has to leave before the end of the session. You've got a tremendous resource with him here, so if you've got anything, put in the chat, raise your hand. This is your chance to ask him whilst he's still awake.
Though I can't promise I will remain awake through the answer.
Duke, while they're thinking, maybe I can ask you something, because that's a very elegant talk on what is a huge topic. But quite often when I listen to that talk, I appreciate how little we know about these things that we've actually been studying for years and years and years. And you gave some little teasers at the end of your talk in terms of future developments. In your mind, what do you think might be the next big breakthrough in informational research, which is going to help us manage these very complex conditions?
Well, I think the easy answer is better biomarkers, and secondly, just more widespread genetic testing with clinical correlation, so that we can identify those specific mutations which are the bad actors, and use that information in addition to the conventional indicators like aortic size. I was somewhat dubious about this very tailored therapy based on mutations, but we in the Loeys-Dietz world, Hal Dietz recently discovered a subgroup of Loeys-Dietz patients with a very specific mutation who were head and shoulders above the others Loeys-Dietz patients, having the worst dissections at the lowest diameter, and with often catastrophic results. And for the first time, he said to me, this is a group of patients. Here is this specific mutation, not even just the gene, but the specific mutation where he said, we have got to be much more aggressive with this. Now, with more data, with more experience, I think we will learn a lot of other patients who are similarly so predisposed. That's going to take a lot of time. I think the biomarkers will be useful in other respects, not just identifying high-risk groups, but more precise and rapid diagnosis of dissection and so forth.
Thank you.
I can see a hand up. Dr. Mohammed?
Yeah, good morning. I have a question in terms of the aortic aneurysm with congenital heart disease, like fellow patients. You know that this type of cohort of patient that will require frequent intervention in the future, like pulmonary valve replacement. Is it logic to address this problem in the same session of other comorbidities?
Is it logical to address it at the same time? Absolutely. Although pulmonary valve replacement, is frequently done as a catheter procedure, but if you're in the operating room with an RV outflow tract reconstruction that needs to be done surgically, and your aorta is just below threshold for replacement, then yes, I think because you're there, I think adding the aorta can be is I think very prudent and doesn't add a lot of risk or time. It's a little more complicated with root replacement. A lot of these patients just have a dilated mid-ascending aorta. That's easy. In fact, getting rid of that makes it easier to replace the pulmonary outflow tract. But with the root and perhaps with a VSD patch and so forth, it's a little trickier. And again, I think the main message here is that some of the traditional criteria of 4.5 to 5 centimeters that we use to decide when to replace the ascending aorta, I don't think that those apply to the congenital heart patients. I just think their aortas are different and a little less prone to rupture or dissect. So, if the dilated aorta is the only part of it, I wouldn't be rushing in to replace the aorta in these patients just because they're around 5 centimeters.
A couple of questions in the chat, Duke. Does cystic medial degeneration occur in all connective tissue disease and bicuspid valve?
I think the short answer is yes. I try never to use that term anymore. Cystic medial degeneration, I think that's just what you see when the aorta comes undone. It's not the primary diagnosis. But yes, I think the aorta, when under the normal systemic pressure and beyond a certain diameter, most aortas start to come undone, and they look the same under the microscope, but that doesn't mean that they all got there the same way.
Okay. And what's your typical post-operative follow-up schedule and imaging modality, so CT or MRI, for the young patient with Marfan or Loeys-Dietz?
Right. Well, it is different based on the specific diagnosis. The Loeys-Dietz patients need very intense surveillance. They really, at least early in life, need almost annual. And with that frequent imaging, MRI is much preferred. And small young patients can be monitored well, sometimes even with echo. With with smaller aortas, older patients, it's just going to be tailored. You know, some Marfan patients we wouldn't see for 3 to 5 years. So it just depends. But
great, thank you very much, Duke. I would encourage the delegates to make use of Duke's invitation to email him to ask that data, because I think you'll find that extremely useful. So very succinct talk. Duke, as always, thank you very much. And we look forward to seeing you next year as well.
thank you.
So next we've got Deborah Harrington, who's a consultant aortic surgeon in Liverpool, who's going to talk to us about the guidelines for aortic surgery. Deborah?
Morning, everybody. I'm going to hopefully share my screen now. Yeah. So, can everybody see that? Can you see that okay?
Yes, we can see it, Debbie, yeah.
Okay, fine. Right, okay. So, morning, everybody. So, there's quite a lot to cover here, actually, in a short space of time. So, once again, I'd like to thank the organisers for asking me to give this talk, and I apologise for the kind of rushed nature of it, but I'll try and sort of go through as succinctly as possible the sort of current guidelines for aortic surgery. So, and I have no disclosures to make. So I'm going to try and cover basically the asymptomatic aneurysm for the whole aorta, so root ascending and arch, descending thoracic aorta, and briefly touch on thoracoabdominal. I'm going to talk a little bit about special populations, which obviously Duke has talked about already. And then very briefly mention acute aortic syndrome and traumatic injury. So the main guidelines in use currently still by all of us who practice in aortic surgery come from the American Heart Association, last updated in 2010, so that's a few years ago now, published in Circulation. And then a few years later in 2014 were the European guidelines, so the ESC guidelines published in the European Heart Journal in 2014. So the mainstay of our guidelines come from both these two documents. So if we're looking at ascending aorta, so this encompasses the root as well. So root and ascending aorta for asymptomatic aneurysm. So this comes from the American guidelines. The standard figure to remember, and this is what we all work on generally speaking, is 5.5 centimeters dimension or greater. This is for aneurysm, dissection, so chronic dissection, IMH, PAU, pseudoaneurysm, so all pathologies essentially. Now, for Marfan syndrome, however, and other genetically mediated, so the aortopathies, this is different, and it's lower basically. So as Duke's alluded to already, it's at 5 centimeters for Marfan's. Now, I'm going to talk more about bicuspid disease, so just hold the thought about bicuspid for now, because this guideline's now been superseded. But basically, for Marfan's, it's 5 centimeters. Also important is if you have a growth rate, so this is in anybody of 0.5 centimeter per year, and also concomitant surgery. So, and this is something I think that as practicing surgeons we see commonly. You get asked about patients who need to undergo valve surgery and what to do with the root and the ascending. And generally speaking, the guideline is that at 4.5 centimeters we would operate on the root or the ascending aorta. Okay, so what about what class 2A evidence? So what's reasonable? Again, so genetic disease, Marfan syndrome. Again, hold the thought about bicuspids. We'll talk more about them in a few minutes. And also patients who have a maximal area to height ratio of more than 10. Now, for Lowe's Deets, as Professor Cameron has already spoken about, the threshold for intervention is even lower, and this also encompasses people who've got confirmed mutations of the particularly aggressive genes, TGF-beta1 and 2. So on a CT scan, it's 4.4 to 4.6 centimetres, and on TOE, it's 4.2 centimetres. So considerably lower for these patients. Other considerations, so symptoms such as symptoms suggestive of expansion would warrant prompt intervention. Patients who don't have root dilatation, or perhaps who are elderly, or then it's appropriate to perform separate valve and ascending surgery. And in patients who have aortopathies, a modified David reimplantation is preferable if feasible, or a root replacement with a valve graft conduit. I'm only going to briefly mention the arch because I know Pedro is going to talk about this in more detail, but essentially the arch guidelines are the same really at 5.5 centimetres. And moving on to the European guidelines, pretty similar in most cases, apart from the bicuspids. So we'll talk a bit more in detail about bicuspids in a moment. So for Marfan's, it's clear that they should have surgery at 50 millimetres. That's a class 1 indication. Patients who have additional risk factors, so Marfan's with additional risk factors, and patients who are bicuspid with additional risk factors should be considered for surgery at 45 for Marfan's, 50 for bicuspids. But for patients with no other elastopathy, the guideline remains at 55. And what do we mean by risk factors? Well, this is things like family history. I think that's very important. Individual patient circumstances are important to consider. So patients that have got a family history of dissection or sudden death in a first-degree relative would be considered to be at increased risk. Also things like uncontrolled hypertension or hypertension that is difficult to control. So those are the sort of risk factors that we talk about. So just to talk in a bit more detail about the bicuspids. So the European guidelines state that in the case of a bicuspid without risk factors, intervention should proceed at 55 millimetres. In other words, the same as patients with a tricuspid valve. This was then later clarified. So there's been a couple of guideline clarifications published in 2016, and then later on again by the AATS, excuse me, in 2018, which look in more detail at this slight discrepancy in the bicuspid aortopathies. And essentially the consensus now is that there is not enough evidence to treat bicuspids without risk factors differently from tricuspids. So at the moment, the current guideline remains 55 millimetres for bicuspids without further additional risk factors. Which is, and that's clarified here. And again, the risk factors, so it does come down to 5 centimetres if you've got risk factors. So this includes things like family history, the growth rate of more than ½ centimetre. The other caveat to place there also is if surgery is going to be at low risk with an experienced team with established expertise. So that is another caveat that is in the updated guideline. So just to talk here about what is new, so just to mention really about the very new guidelines that have just come out from EATS, a European Heart Journal, just a few weeks ago, on the new valvular heart disease guidelines. So there's a little section there about aortic root and ascending aneurysm, and they have just slightly revised their wording here, suggesting that valve-sparing root replacement is recommended in young patients with root dilatation if performed in experienced centres with durable results. So this is now, they've taken out the wording about tricuspid. So in other words, it's applicable to bicuspids as well. But again, it kind of assumes that you have, or it suggests that you should be doing this in experienced centres with durable results. And I think the other thing to sort of talk about, which I suspect has already been talked about in other sessions, is that there's much more of an emphasis now on multidisciplinary meetings and discussion with the heart team as to the best intervention for our patients, and this is obviously in line with our current SCTS thinking as well. So just to move on and talk about descending and thoracoabdominal aneurysm. So for isolated DTA aneurysms where you have either chronic dissection or connective tissue disorder in patients that are otherwise fit, then open repair is recommended at 5.5 centimeters. If possible, for degenerative, traumatic, saccular, so on, then endovascular treatment is recommended. And for thoracoabdominal aneurysms, these are obviously at higher risk for surgical procedures. So the recommendation is that surgery proceeds at 6 centimeters, but again, this is less in patients with connective tissue disease. So again, in the Marfans and the Lowe's Dietz patients, this would be, we reduce the threshold accordingly to 5 centimeters or even lower, perhaps 4.5 centimeters for the Lowe's Dietz patients. And this is the European guidelines are similar. They suggest that TEVAR should be considered rather than surgery if possible when anatomy is suitable, and this should be considered at 55 millimeters for descending, and surgery, if surgery is going to be considered, that this should be at 60 millimeters in patients who don't have an aortopathy. Just to briefly talk about acute aortic syndromes. So the AHA guideline states that all patients with any type of dissection, regardless of location, should undergo urgent surgical consultation. And as we know, type A dissection should be urgently evaluated for emergency repair. And that descending dissections or acute aortic syndrome should be managed medically unless there are complications. IMHs should be treated according to the segment of the aorta in which they are present, and the indications for TEVAR. Remember, this is 2010, so this is going back a while now from the American Heart Association. The class 1 indication for TEVAR would be acute type B complicated dissections with a 2A indication for penetrating ulcer or intramural hematoma, and then the TEVAR may be considered if you have uncomplicated acute type Bs or subacute type Bs. Now this was obviously before the results of the INSTEAD trial, which then and the European guidelines were published after the results of the INSTEAD trial, which suggests that in uncomplicated type Bs, TEVAR should be considered. Now, I don't know what's happening around the rest of the world, but certainly we are not actually doing this at the moment. We are discussing more and more of our acute or subacute type Bs in our MDT meetings, but we certainly don't have capacity to stent all of our type B dissections here at the moment. But this obviously could change in the future. I'm just going to mention the concept of non-A, non-B dissection, which was talked about in this very nice paper, which was a position statement from the European Society and also the European joint position statement with the European Vascular Society a couple of years ago. And this introduces the concept of non-A, non-B dissection, which essentially, in terms of severity and in terms of risk, falls somewhere in between the type A and the type B. It certainly seems to have a more malignant course than type B dissection, but perhaps not so severe as type A. But we certainly would manage these more aggressively, generally speaking, than type B dissections. I think it's fair to say. So we certainly wouldn't manage them at a distance like we would perhaps for type B dissections. We would certainly be certainly more aggressive in terms of either managing them or rescanning them if we're not going to operate on them immediately. Just very briefly then to just mention trauma, essentially in cases of acute traumatic disruption of the aorta, the standard treatment now would be for endovascular intervention, and I think that is shown in both sets of guidelines, both the American Heart and the European guidelines. So in summary, that was a very brief run through. But basically, we've talked about the indications for intervention on all segments of the aorta. We've talked about asymptomatic aneurysm, special considerations, and I think that's important. And it's increasingly important, really, now to individualise for your own particular patient, and to discuss with the your local MDT. And a lot of this now does depend on local expertise, as well as individual patient factors. We've briefly talked about acute aortic syndromes and also mentioned trauma. So I'd like to ask if anyone has any questions. Thank you very much.
Thank you, Deborah. Deborah, could you put your bicuspid valve slide back up, because we've got a question.
Oh, right. Okay. Yeah. The one about I'll go to that one.
So in the case of surgical AVR, does the 4.5 centimeter indication just apply to bicuspid valve or also to tricuspid valve?
No, so it would apply to both. So I think, if the patient is having an AVR either because of stenosis or regurgitation, then the 4.5 centimeter consideration applies to all bicuspids and tricuspids. Obviously, it depends on the the patient, so it depends on the comorbidities of the patient, the risk of the procedure and so on, but generally speaking we would certainly consider intervention on either the root or the ascending at 4.5 centimeters. Does that answer the question?
It answers it for me. I hope it answers it for the delegate. I'm just trying to look to see whether we've got any hands up anywhere. There's nothing more in the chat. Malcolm, can you see anything?
No, but I can ask Debbie something, actually. In all of the guidelines, Debbie, they're talking about absolute size. Now, Duke mentioned the importance of indexing size in a particular form of arteriopathy. But in general terms, is indexing something that's coming up in the guidelines, or are we going by just an absolute size requirement or change in size over time?
It is mentioned. So I mean, here you can see that it's mentioned. They do talk about this area to height ratio, which is known to be a predictor. And I think it is important in patients of small stature. I can certainly think of a few patients where clearly the aorta may only be around sort of 4 centimeters, but in a small woman, for example, you can clearly see that it's really quite big for their size. So I think we obviously, again, I think it's important to sort of individualize treatment and so on, but I think that is important in patients of small stature. Does that answer your question?
Thank you. It does, very clearly. Thank you.
Thanks very much, Debbie. So I think in the interest of time, we'll move on. So Pedro Casrino, who was formerly a surgeon in Papworth and has moved out to the US. It's a pleasure to have Pedro back on board. Pedro, welcome.
Thank you. Thank you very much for the invitation. And I hope you can see my slides, though I don't know why I've ended up right at the end of the talk.
Yeah, we can see your slides, Pedro. Thanks.
Okay, great. So I'll kick off. and I'll get straight into it. I have no disclosures. This is a talk. Aortic arch surgery, I think, is really for the specialist aortic surgeon. And I hope this talk is aimed at the general cardiac surgeon and understanding what options are available. And it's not designed for the sort of expert. So I'll start off just with some anatomical points. The first thing is to point out that there are lots of different segments of the aorta, of the aortic arch in particular, which are derived from different embryological origins, and that's likely to influence the pathology of the ascending aorta and the aortic arch in particular. We increasingly use the language of endovascular surgery, and you need to know what these zones are. So zone 0 goes up to the origin of the innominate, zone 1 to the origin of the carotid, zone 2 to the origin of the left subclavian. Zone 3 is 2 centimeters beyond the left subclavian, so that's a bit arbitrary, and zone 4 beyond it. And beyond zone 4, you actually have zones 5 to 11, but I won't get into them today. The picture on the left is to emphasize the relationship of the vagus nerve and the recurrent laryngeal, which is very important in aortic arch surgery. And I would say that usually in first-time surgery, you can actually see the recurrent nerve quite well, and so you can preserve it. The problem is much more in redos where there is difficulty. And sometimes people are confused by, there are sympathetic branches which come with the vagus and cross the arch more medially than the recurrent laryngeal nerve. And sometimes you may get confused that those sympathetic branches are your recurrent, but they're not. The picture on the right is to remind me to tell you that the key to aortic arch surgery is the left subclavian artery. And you can see that the arch doesn't go from right to left in the chest. It goes from anterior to posterior. And the left subclavian artery can be very posterior, especially if you've got a dilated arch. And this origin ends up, right back here where the spine is, and makes reanastomosing it really quite challenging. The other feature of the left subclavian artery is this first branch, which is the vertebral artery. And when you look at your CT scan and you're planning aortic arch surgery, please look at where that vertebral artery comes off, because it may come off quite proximally, and so you don't want to damage it when you clamp or dissect around the base of the left subclavian. And of course, you need to be aware of the various anatomical variants. So that left vertebral artery may in fact come off the arch directly, and that'll be the case in 1 in 20 patients. And you really must be attentive to that, because this vessel needs to be reimplanted. The third image shows a bovine arch where the left carotid artery comes off the innominate artery. And that's really quite common, 11%. And then more rare is this aberrant right subclavian artery with typically a retroesophageal course and a very posterior presence of the right subclavian artery basically in the posterior mediastinum. And of course, if you cannulate the right axillary artery for your standard bypass and selective antegrade cerebral protection, and you haven't realized that this is the anatomical situation, you're going to run into big trouble. Understanding that the circle of Willis is not always complete is very important. So only 50% of patients have a complete circle of Willis, and most commonly the defect is somewhere in one of the posterior communicating arteries. I have to say, I took this image, it was recently made for me for one of the patients I was planning to do arch surgery on, and it really shows the advances in CT cerebral angiography that allows you to decide whether or not you're going to have adequate cross circulation to use unilateral flow. But I would say that regardless of what you think is happening in the circle of Willis, there are further collaterals at the level of the external carotid and elsewhere, which can mitigate the issue of an incomplete circle of Willis. So just moving on to indications, these famous images from Eleftheriadi's natural history paper, the top one for ascending and the bottom one for descending. Unfortunately, there was no arch natural history. And so typically we end up intervening on the arch when it's aneurysmal in association with an ascending or in association with a descending. And typically the arch isn't the bit that's reached the threshold to mandate the intervention. In the arch, you do more commonly get symptoms, whether that's hoarseness or whether that's because of the relationship to the trachea, bronchus, and esophagus. Symptoms are more commonly a precipitant for operation than with the ascending or descending. And as Deborah told us before, on its own, if it reaches 5.5, that's an indication for intervention. And whether it's a true aneurysm or a chronic dissection doesn't matter for that threshold for intervention. And I put this little cartoon up of a saccular aneurysm to emphasize that typically the radiologist reports the dimensions of the little bobble. But in fact, when you're deciding whether or not to intervene, you measure the distance across the diameter of the aorta and the protruding saccular aneurysm in order to decide whether that needs an intervention or not. And one of my favorite topics is the need to do arch surgery in acute type A aortic dissection. And I think there are some reasons that it's mandatory to do the arch. I list these on the left. If the tear is in the arch, you have to replace the arch. And if there's an existing aneurysm of the arch, the same. And I also think if you have malperfusion of the territories of the supraortic vessels, you should be doing an arch as well. If you have distal malperfusion, so if you have intestinal or even limb malperfusion, lower limb malperfusion, then it makes sense to do the arch, but in the context of doing a frozen elephant trunk as well. And a frozen elephant trunk is also useful if your arch tissue is very friable and you think you're going to have problems with bleeding if you do a more conservative operation. And I put in brackets here prophylactic, which is the strategy of doing arch and FET in all type A's under a certain age to prevent the need for early reinterventions. So getting on to the meat of this talk, how to operate on the aortic arch. And there are obviously numerous options and there are different temperatures, and invariably you need to use some sort of hypothermia. You need to have some form of circulatory arrest. And then you're going to have more than one perfusion line and perfusion circuit. And you may do some of your surgery with clamps on and some with open anastomoses. Essentially, I think they come down to two options. You can do the branches first or the arch first. And I'm going to talk you through how I would do the arch first, which is my standard way of doing it. And this Birmingham review course is very much a preparation for the FRCS Part 3 exam. And you often get asked, well, how do you operate on anything? And I like to say that it's a good idea in your head to break it down into what you tell your anesthetist, what you tell your perfusionist, what you tell your scrub nurse and your assistant, before you get into the meat of the operation. And I think with aortic surgery, it's very helpful to do this in a group with a picture on the board in the operating theatre. So these are the sort of things you need to be discussing with the anesthetist. And this, really demonstrates that you have an understanding of what the surgery involves. So you need arc lines before and after the arch as a minimum. You might even want a left radial arterial line in addition. Bleeding is a big issue, so you need large bore venous access and you need the Belmont to rapidly infuse blood at the end of the procedure. If you think you might be cannulating the carotid artery extrathoracic, then you might want to ask the anesthetist to leave one side of the neck free and prepped. Temperature probes are key, and the nasopharyngeal temperature is basically the brain temperature, and the bladder temperature is your spinal cord temperature. And if you understand that, you won't make mistakes about what temperature you're striving for. And usually the nasopharyngeal temperature you get to much earlier than the bladder temperature. Bladder temperature may be an issue if you don't have good renal perfusion, but I think it is a good indicator of what your spinal cord is at. Cerebral NIRS is really mandatory, and not only discussing with the anesthetist that you'd have cerebral NIRS, but what strategies they might employ if the NIRS were to drop. And I'm thinking of not just additional perfusion lines, but how they might manage the hematocrit or the PCO2, both of which can help improve the cerebral saturations without changing what you're perfusing. They should have a head cooling jacket. And then whether you use pharmacological adjuncts is really, I don't think there's very good evidence. I've always used methylprednisolone, but I don't think there's strong evidence for that. And I think, basically you end up using what your unit has in their protocols. You should consider the need for spinal drain and the timing of that. But I have to say it's very rare for me to have pre-operative spinal drainage in arch surgery, even including doing a FET at the same time. You might discuss the TOE findings, what inotropes you want at the end, and you're likely to need blood products. So some sort of discussion with hematology is important. And then the perfusionist, this is a very intricate perfusion issue. You're going to have different cannulations, and you need to be clear about when and where you're going to be using which circuits. Choice of temperature is important, and I put up here on the right an indication of what you might feel safe with for circulatory arrest. I think mostly now, most people would be using some sort of selective antegrade cerebral perfusion at least, in addition, which mitigates the safe period, so extends the safe period here. But I think it's really good to know, what is safe for you to completely switch off the circulation should you need to. And then what sort of myocardial protection you might use is important. You're going to have a long cross-clamp time, or you may use strategies to reduce the cross-clamp time. This is your basic circuit. So most people would use some sort of right axillary cannulation, usually through a graft. It gives you lots of options. But you can drain from a two-stage in the right atrium, and then you start cooling, and you can pick any temperature between 20 and 28, dependent on your experience and how difficult you think the case is going to be. While you're cooling, you can do whatever you need to do in the proximal bit. So you can put a clamp on the ascending aorta and do a root operation or an ascending procedure, and give cardioplegia to do that. And when you finish that bit, you're still going to have a good, in my hands, like 90 minutes, before you're going to reperfuse this heart. And what I do is I reintroduce warm blood into this aortic root. So I keep the heart perfused with warm blood, which I just run from the cardioplegia circuit. So it's a bit like a hot shot, but without cardioplegia. And just to show you what that looks like in these pictures. So this patient didn't need any proximal surgery. And you can see I've got my root vent cannula in the ascending aorta. This is just what you would use for cardioplegia. And the cross clamp looks a little funny because it's placed the other way around. And that is to allow you to separate the cooling circuit, which is in the arch and beyond, from the warm blood circuit, which is going to the heart. Of course, most commonly, you have to do something to the proximal. So in this case, sorry about the volume. So in this case, there's a need for a root procedure. And you can see I've done the root procedure and used a graft with a chimney and put the cardioplegia into the chimney, but the cross clamp is the same. And instead of going across the ascending aorta, it just goes across the graft. And the heart beats throughout this time. And it really does help you reduce your cardioplegia time and your cold ischemic time. So then once you reach your temperature, you need to clamp the supraortic vessels. And it's important to clamp both the left carotid and the left subclavian. And this prevents steel and pressurizes both the cerebral circulation and also the vertebral circulation, which is important for the spinal circulation. And this is what I do when I have reached temperature and switched off. So this is what I call the zone 2 setup. So the patient is now drained, there's a clamp on the innominate, and there's blood, there's selective antegrade cerebral perfusion going down the right axillary artery and into the supraortic circulation. So here we've transected the innominate artery, and I'm about to transect the carotid artery. And you'll see that it's not clamped, and I'm just seeing, okay, is there backflow? Yeah, there is backflow. So normally I'd be quite happy just to clamp this and carry on with the procedure. But if you need to, you can also give bilateral cerebral perfusion. And this is a retrograde cannula going into the left carotid artery. There's a snare placed around it to just stop it popping out. And that can be wide to your axillary cannula. And now you're giving bilateral perfusion. And I said this was a zone 2 setup. So I'm not going to go beyond the left subclavian. And I just want to show you how I deal with the left subclavian. So here I've transected the distal arch, and we're just proximal to the left subclavian. You can see the left subclavian there. And now I'm clamping the left subclavian to pressurize that vertebral circulation, transect the left subclavian, and I'm just going to oversew it with a plegited suture. So although, most likely I would normally put a frozen elephant trunk down there and the stent would give you the closure of the left subclavian, I think it is important to oversew it. And I have to say, now that I moved to the States and cost is not an issue, we just use a vascular stapler across this. And then this is the next picture. Oh, yeah. So when you're doing your the distal arch setup, so after you've done your left subclavian artery, I like to put these 3 plegited 3/0 sutures in they're basically like a Mercedes-Benz, 120 degrees each. And you can see in the cartoon what it's supposed to do. And that allows you, when you put your graft on, the collar of the graft is a bigger diameter than the arch, or maybe not, but it really helps you with those 3 stay sutures. It helps you orientate your cuff in relation to the arch and allows you to make that symmetrical and well matched. And then apart from the stay suture, I then just use a running 3/0 suture to do the distal arch anastomosis. And then actually most commonly, you're not dealing with true aneurysms in the arch, you're dealing with chronic dissections. And so what you look at in the distal aorta is this, where you've got a false lumen and a true lumen. And it's very helpful to use your stay sutures to help you compress the false lumen a bit and distribute the false lumen, which has a bigger circumference, around the circumference of the true lumen. So I use exactly the same technique for that chronic dissection. And then once you do your, so here the cartoon now has the graft in place. It may or may not have this stent or elephant trunk, but it will have a perfusion line. So it allows you to reintroduce distal perfusion immediately that you've done the distal anastomosis, and you can reperfuse the body while still being able to sequentially reimplant the supraortic vessels. And meanwhile, all this time your heart is being perfused with warm blood. Okay, how about the question of whether you do this as an island or a trifurcation? My preference is the trifurcation, but of course the island was used in the times when time was very important. You were doing under DHCA. Often this part of the arch is diseased. And the other thing I would say that by Laplace's law, the tension on your sutures is greater here in the island technique than here in the trifurcation technique. And so you're going to have more bleeding with a Carrel patch. So I vote for the one on the right. And then a small point about if you're doing a chronic dissection, if you do a floating elephant trunk, you really need to cut back this septum. You see the septum here? you have to cut it back. So the floating elephant trunk ends up perfusing both sides. If you don't cut back the septum, you're liable to cause malperfusion. And also it's difficult to get the floating elephant trunk into the small true lumen. If you do a frozen elephant trunk, you can afford to put it in the true lumen. And then the final point about arch is this is a bit of bovine pericardium. And often, so often I've seen this where it's too long. Basically, you do a graft to graft, they're too long, and it pokes up into the back of the sternum, and the dacron, erodes into the sternum if you don't cover it with bovine pericardium and try and stop you having a problem with a further operation. Okay, so I'd like to move on to hybrid procedures. And I'm not talking about hybrid as in open placement of the endovascular stent, like in a FET, or even endovascular completion of a FET. With hybrid, I'm really talking about debranching, where you do open debranching and then some sort of endovascular procedure. And typically it looks something like this, where you sequentially debranch innominate, left carotid and left subclavian, and you put it somewhere on the ascending, and that allows you to come back later and put in a stent. Now, I'm not a great fan of this. Usually the aorta is diseased, and that's why you need to do a stent in the first place. So doing it off pump isn't great, because putting the side biter on is a great stress on this diseased aorta. So you have to do a median sternotomy, you have to do it on bypass. And often you actually have to replace a bit of ascending aorta anyway, either because the ascending is abnormal or because you need it to give yourself the landing zone for the stent. And the work of doing all the debranching, I said to you, the most difficult bit is the left subclavian. You have to do that anyway. So I'm not a great fan of hybrid procedures. Where maybe they have a role is where you do some separate carotid to subclavian bypass that allows you to avoid having to deal with the left subclavian artery. And as I've said, these are hybrid procedures, I think, have a lot of the disadvantages of the full anatomical replacement without really any great benefits. Of course, you can avoid doing any sternotomy or bypass if you do carotid to subclavian bypasses and then do endovascular. So this is typically a vascular procedure where the surgery is done outside the thorax in the neck. And here you can do carotid to carotid bypass with the subclavian, allows you to put this stent more and more proximally. At the end of the day, you're dependent on this inflow into the innominate artery. And so really, and there are studies that compare hybrid and the full open procedure, they generally show a faster recovery because you have a less of a DHCA time, but they are they're durable. And I see that they're basically preferred in units that are vascular led. Where I think they may be very useful is this is a type A dissection. And here, it was a conservative repair, but they did reimplant the innominate artery proximally on the ascending graft. And as the false lumen progressed, then the patient had a carotid to carotid bypass, and we were able to come back and do an endovascular procedure right up to the base of the innominate. You can see that this stent is come right up to zone 0, and we're relying on this debranched innominate put in at the time of the dissection to perfuse the left carotid and left subclavian. And just one final point about a hybrid procedure. You may have seen this Cyrus medical dissection stent, which is an adjunct to a conservative ascending repair for type A, where you put this bare metal stent across the arch, a bit like the sort of petticoat extension for type B stenting in the descending. And so if I move on finally to endovascular procedures, I know time is pressing. There are a lot of difficulties with endovascular procedures, and the main difficulty is that the outside of any curve is longer than the inside of any curve. And there's, that's just, I don't know, maths or physics. It's difficult to get around it. And that is the big problem with arch stenting. And often the arch can be quite angulated as well. You have higher forces than you do doing TEVAR in the descending aorta. And also there's more mobility with the pulsation. There are issues with tissue quality and if the tissue is of poor quality, and by that I mean there's atherosclerosis, you have the issue of supraortic embolization or indeed occlusion by your stent. And then if you need to put wires in, they may end up abutting the aortic valve, and if you've got a mechanical valve, that can be an issue. But there are numerous devices, some single branched. There are 3 companies make a single branch, 2 companies have multi-branched stents. They're all investigational here in the US, but they are used in Europe and Asia. And I'll show you, we use this Gore thoracic branch endoprosthesis at Cedars, and it's very versatile. You can, versatile, I've seen my accent's already changed. You can use it in zone 2, zone 1, or zone 0. And really can get quite good results. Here are the stages. I don't know if you can see that 2 guide wires, the blue guide wire, which is in the arch, and then the green guide wire, which goes into the left subclavian artery. So you put guide wires in, then you put up the aortic component into the arch. You deploy it and withdraw the catheter. And then you put up the introducer sheath over the green guide wire into the left subclavian and deploy that branch. So it's relatively simple. It does require more of a learning curve than straight TEVAR in the descending aorta. And here's a case, patient with a very large descending thoracic aorta, but you can see a relatively normal arch. And so that had a good landing zone. So he's had his carotid and subclavian bypass done in the neck. And then he's also had a TEVAR in the descending aorta. And here deploying this thoracic branch endograft in the arch with a branch into that innominate that is feeding all the other vessels. You can see a really good result with absolutely no endoleak. So just to finish, my take-home messages are, that open arch surgery is the gold standard. And really, the results have improved a lot over the past decade. And I haven't said anything about outcomes because I think they really are very variable unit to unit and patient to patient. But broadly speaking, a center of excellence with a not very complex patient would be suggesting a mortality of 5%, a stroke rate of 3%, and a paraplegia rate of 2% if they did a frozen elephant trunk. And the endovascular options really augment what patients can be offered. They may be the only option in very high-risk cases. Really, I think they're part of the improvement in the results for open surgery. And certainly that I think the frozen elephant trunk has been a major advance for open aortic surgery. And just to give you an idea, mortality rates with arch stenting are variable. They can be 0 to 5%. But stroke rates have, in all the series so far, been really very high, with at least at around 15% and going really up to 30, 40% stroke rates. I know it's early days, but those are the sort of figures which you should be comparing with the open arch surgery. And the final message is that patient individualized therapy is the key. And to offer that, you need a team that has all the different skills and competencies. So thanks very much. I'm happy to take questions.
Thanks very much, Pedro. There's a few questions in the chat. Malcolm, there's one about type A dissection with malperfusion, immediate repair or treatment malperfusion first. Can we keep that, I think, for the first case, because I think that's a dissection scenario. So if we could, if you can remember that, that'd be great. Pedro, how do you choose between a frozen and a classical elephant trunk?
So when I was in the UK, I had on the shelf all these floating elephant trunks, and they all went out of date because I basically stopped using them. So I almost never use a floating elephant trunk. I think every situation can be dealt with by a frozen elephant trunk. Of course, here in the United States, we don't have the frozen elephant trunk, so you have to sort of build your own. So I have been using floating elephant trunks here. But, you know, once FDA approves the frozen elephant trunks, I think I will stop using a classic elephant trunk completely.
Malcolm, any comment about that?
Not really. I think I've sort of come to the same conclusion. I think in the past there was some concern about doing an open second stage with a frozen elephant trunk because the stent wasn't necessarily designed. It could be porous. You don't know what it's going to stitch like. But I think that's not a concern anymore. And I agree, most situations now, we'd use a frozen.
Can I just add something? We still do use a floppy if we are going to be doing an open second stage as a planned procedure. So, for example, in a young Marfan with a chronic dissection where we're going to be doing an open thoracoabdominal. And so the important thing to say here is that these patients, particularly the chronic ones, obviously in an acute situation, you would use a frozen, I think, but in a chronic case, these should all be discussed in an MDT before you operate on them, so that you have a plan for the second stage. And I think that's really important for people to stress.
Thanks, Debbie. There are two questions pertinent to your presentation. I presume, Pedro, you were showing images of someone else's scans when you showed the kink graft. How do you address the kink graft after a complete anastomosis?
You can't. I mean, so I know people put just interrupted mattress sutures on the lesser curve. I'm not a great fan of that. You basically have got to make the graft shorter before you do the graft to graft. But it can be difficult, you know, I understand that. What you do need to do is stop it poking up, you know, at the end of the case, as you pressurize everything, it pokes up and it burrows into the back of the sternum, so that when somebody has to come back and operate, they have to go directly into it. And that's what I made the point about the bovine pericardium. But also, if you've got bits of graft which are in the pleural space, you should protect the graft from the lung as well. So please put bovine pericardium across that as well.
And there's a question about your technique of instilling warm blood and clamping the graft or clamping the aorta. And they're worried about, I guess they say inducing myocardial ischemia. I guess it's about increasing myocardial oxygen consumption.
So the heart is empty. And there's invariably put an RSPV vent in. So it's empty, beating. I think myocardial oxygen consumption is up because the temperature's up and it's beating, but compared to being still and without an ischemic, it's really better. And I guess, you know, I'm very comfortable with perfusing the donor heart on various machines. And, you know, as you probably are also familiar with, Aaron, we get better results with OCS perfused donor organs than we do with leaving them in an ice bucket. So that's really what stimulated me to move to this warm perfusion.
And I guess the important point is you've got everything vented, haven't you?
Yeah. And I think also I look at the ECG. I don't really follow what's happening with the ST segments, but the width of the QRS, I think that's the key thing. So I want to have a narrow QRS and an ECG that I can follow, and I may adjust the flow rate accordingly. But I can't think of the time when I've been so unhappy with that situation that I've ended up just pledging the heart and saying, look, I'm not happy that I've got good perfusion. The heart's stressed. Let me bail out of the warm perfusion and just pledge it. I probably did in my very early experience doing this, but not in the last 50 cases.
Thanks very much, Pedro. Pedro, there's some more questions which are coming through in the chat. Would you be able to just answer the chat directly?
Yeah.
Debbie, I hope is going to answer the question about cerebral perfusion in her case. But if not, we can talk about it as well during that. So I'm going to hand over now to Malcolm, who's going to run the case. We've got a number of cases. Welcome to Mark. Lovely to see you. So Malcolm.
Okay, thanks, Aaron. So we've got about an hour now, and we've probably got 3 or 4 cases. I hear poor old George is out and back in the operating theatre, so he's earning his NHS salary. So we've got cases from Eshan. Debs has got a couple, and Mark's got one. So can I suggest that we do Eshan first, then Deborah, then Mark, and then back to Deborah if we've got time? Would that suit everybody? And again, for the audience, as the cases are being shown, any questions, please put them up in the chat. We can answer them directly afterwards, or if there's no time, we can direct the presenter to answer you directly in the chat. So Eshan, if you're ready, we could start with your case, please.
Thanks, Malcolm, and thanks for the opportunity to present this case. I've got a very tight brief in that we were going to start off with cannulation strategies, and this is a brief case to outline that. And I've got a couple of slides to summarize how you would approach cannulation strategies. Can everyone see my slides?
Not yet. Okay.
How about now?
Yes.
Thanks. So I've gone for the most obvious aortic emergency, and I'm going to give you a brief summary of the case. This is a 44-year-old lady who presented with sudden onset chest pain, radiating through to her back. She's got a background of Marfan Syndrome. She's previously had a Crawford Extent 1 a few years prior to her presentation this time round. And we know that she's got a stable type B dissection. She's otherwise fit, well, and active. So slightly complicated in the background, consistent with connective tissue disease, and she presents with this CT scan. I'm just going to run the CT scan, and it's a cycle, so it'll keep running. Malcolm, if you don't mind, can you pick some delegates from the audience to comment on the CT scan once it's had time to run through?
I think that might just be beyond me because I haven't got a list. I don't really know who they are.
Aaron, are you able to?
Have you got some names, Aaron?
Yeah, I've sent you some names on the chat, Malcolm. People who participated before, or if anyone wants to shout out, that's fine.
Okay, let me look. Is Jason Ali here? Jason, would you mind giving just a little talk through? You can unmute yourself.
Hi.
Thank you so much.
So from what I can see from the images, there's a type A aortic dissection, which seems to extend down into the, seems to be extending as well. And well, can I see this image again from the top?
Yeah, it's playing again for you, and let me know if you want me to stop the scan at any stage.
Well, there's a type A aortic dissection going down into the aortic root, and then separately in the descending aorta, there's the appearance of presumably related to his previous episode, appearance of a sort of true and false lumen, which are both equally opacified, going down into the iliacs.
Can you comment on the extent of the dissection within the arch?
It sort of is juttering, so I can't see the images perfectly, but it seems to be I could see the dissection flap in the arch, but I couldn't clearly see extension into the branch vessels because it was sort of seems to jump.
I'll try and stop the scan where may give you a clearer picture.
So it seems to be extending into the left subclavian.
Okay. And you suggested that it is extending down into the root.
Well, it seems to be going into the proximal ascending aorta at least, but
so based on your findings so far, how extensive do you think you would need to repair this aorta?
I would like to measure the dimensions of the root. In the context of Marfan's disease, I think you would have a low threshold to replace, to perform root replacement, depending on the dimensions. And there's already depends if we can identify where the tear is, but again, and I would like to measure the size of the arch as well.
Malcolm, are you able to identify another candidate?
Yes. How about Neil Curran? Are you in, Neil? Or Peter Lang?
Hi, yeah. It looks like I've just seen a shot there of the aortic root at the level of the sinotubular junction. Looks like the aortic root would need to be replaced.
Yes, Peter, so the cardiologist has kindly done a scan of the heart, an echocardiogram, and there's severe aortic regurgitation.
Okay, so I would have to examine the aortic root and the valve at the time of operation, but it seems like it will have to be replaced.
So currently we have a plan to replace the aortic root. We've identified that the arch is dissected, possibly a dissection flap in the left subclavian artery. I'll just go back to that shot, coming back to what Pedro was talking about regarding the orientation of the subclavian artery. Just have a look at the position of this subclavian and arch vessels. Any comments?
The subclavian looks quite posterior.
That's exactly right. Well done. So if you look at the AP diameter of this chest, you've got the trachea there, and the subclavian is well posterior, almost lateral to the spine here. So you can anticipate that this will be a difficult subclavian to control, and arch vessels are also quite posterior and not in their typical orientation. Any comments on how you would deal with that and how you would deal with the descending thoracic aorta? We've heard some very elegant talks earlier about the indications for surgery on the descending and the arch, and managing this in acute type A. Peter, are you still there?
Yeah, I'm still. I think you'd have to do a frozen elephant trunk so that the descending can be intervened upon at a later stage. But I don't know how to deal with that posterior left subclavian.
Okay, thanks. Well done. So I think in summary, we're looking at a patient who needs an emergency operation, and we're looking at an extensive procedure involving the root, which possibly needs replacement, arch that needs tackling, a subclavian that's difficult to manage, and possibly an intervention on the descending thoracic aorta at the same time, given the history of this patient. So putting that all into context, how would you and again, keeping to the brief, how would you approach cannulation strategies in this patient? If you can talk to me about first your arterial cannulation strategy and then your venous cannulation strategy.
I think we're still torturing you, Peter, if that's okay.
Okay, right, yeah. So the innominate artery is not dissected, so I would cannulate the right axillary for arterial inflow. For venous outflow, you can't really use the femoral, I suppose, because the descending is there's perfusion in the false lumen. I'm not sure if can you use the femoral vein?
Malcolm, shall we give Peter a break?
Could you use the femoral vein for venous return to begin with, before chest entry?
You can do. Is that what you would do?
Probably not. Probably I'd use the axillary for arterial inflow, open the chest, and then cannulate the RA for venous return.
Okay. Thank you, Peter. Malcolm, do you have another candidate?
Yes. Aravinda Page. Aravinda, are you in?
So I'll just keep the scan running so that everyone can see how bad this dissection is.
If Aravinda's not in, Yasir Iqbal? Yasir?
Hello.
Sure.
I can go in. Hi.
Okay, I think Aravinda's back.
Yeah.
Aravinda.
Hi, Aravinda. Thank you.
Hi, sorry. I had a problem with my mute.
So you've decided to take this patient to theatre and you're just about to brief for this case. And we're briefing just particularly on the cannulation strategies that you would adopt.
Yes, I understand the question was, the question being the next stage.
What cannulation strategies would you adopt and how would you describe this to your anesthetist and perfusionist?
So in terms of, I'd ask for arterial lines in the right and left radial artery and femoral arterial line. But as Peter said, I would adopt the same cannulation strategy by cannulating the axillary artery prior to the stenotomy and then go for a right atrial cannulation with the two-stage pipe for venous return.
And would you approach the axillary artery directly or would you put a graft onto it?
We'd generally, at our institution, the practice would be to put a 10mm graft onto the axillary artery and thereby the 3/8 kind of tubing would connect directly to that with a 3/8 connector.
And once you've gone on, how would you address cerebral perfusion? Would it be unilateral just through the axillary artery or would you continue to explore selective antegrade cerebral perfusion?
So it would be, yes, it would be unilateral, but we'll have nurse monitoring in place to ensure that this was an adequate strategy and that there was no issues that developed, to ensure that no issues developed during the case.
Thank you. Yasir, what would your approach be on this case?
Morning. So my approach should be similar to sort of what Aravinda has described in terms of setup for the cardiopulmonary bypass. So once the axillary cannulation is established, then to proceed with opening the chest. And was there any pericardial effusion noted on the echo at all?
No, there's no pericardial effusion.
Okay, so once the pericardium is opened, I would then proceed cannulating the right atrium and go on to cardiopulmonary bypass. Was there significant aortic regurgitation on the echo as well?
There was.
There was, yeah. So I tried to initially give some direct plegia, but then to put the clamp on, open the aorta, and give direct cardioplegia to the coronary ostia, arrest the heart, and examine the root. And from the echo appearances and CT images, it appears that the root needs to be addressed, and I would opt for a root replacement. In the meantime, try to cool to around about 28 degrees. And then whilst doing the root replacement, once that's been performed, to then examine the arch, I'd ask the perfusionist to drain the patient, remove the clamp, and do an open arch, do open clamp, and examine the arch and see the entry tear. But I think this patient needs an extensive operation and would require a frozen elephant trunk, as mentioned earlier.
Thanks, Jesse. I'm just going to stop you there. So I think most people are suggesting auxiliary artery cannulation. Are there any other options if this proved to be difficult? So this patient's not the slimmest. Your approach to the axillary artery is quite far away. You may run into trouble if you're not familiar with the technique and haven't adopted that routinely in your practice. Any other options for arterial cannulation in such cases?
I think it's centrally in the aorta with the Seldinger technique.
And what adjuncts would you need for central arterial cannulation with the Seldinger technique?
You need a TOE and to guide you that you're in the true lumen, and so as you pass the needle and wire, that you're in making sure that you're in the true lumen at that stage before you pass the cannula in.
How would you know that you're in the true lumen looking at the TOE?
Again, you can put a color flow into the across the lumen and to see the flow through the aorta. In addition to the size, the false lumen, the true lumen would be smaller in size.
And looking at this particular case, the true lumen, if you could identify it, is quite small. Yeah. So that again will be quite challenging even for the anesthetist to identify that you are certainly in the true lumen. Yeah. As a surgeon, inserting the needle into this aorta centrally and trying to place a guide wire, what would you be looking for when you're inserting this needle?
You'd be looking for sort of two flashbacks through the needle. So firstly, as you're most likely to hit the false lumen, you'll get a flashback, and then you'll puncture the septum between the false and the true lumen, and you'll get a sort of a second flashback.
Thanks. Any other arterial cannulation strategies?
There is a sort of samurai technique. You don't transect the aorta. And
can you take me through the principles of the samurai technique?
So you would have to have your aortic cannula connected to the arterial line from the cardiopulmonary bypass circuit, primed and ready, and you'd have a tape around the aorta. Pump suckers would be needed to be in the chest, patient obviously heparinized, and the aim would be to transect the aorta and then engage the cannula into the true lumen directly and then snare down on the cannula at that stage.
So you would need to have established venous drainage and yes, empty out the patient.
Yes. Yeah.
Under a brief period of warm circ arrest.
Yeah.
Thanks. Thank you everyone for their comments and their engagement in the case. I think for the interest of time, I'll just run through my summary slides. I think as has been discussed, there are multiple ways of establishing cardiopulmonary bypass and cannulation strategies. It's very much dependent on your personal experience, practice, what you're comfortable with. But ultimately, adopting a safe strategy is the bottom line key message here. But I'm going to just run through some slides. So when you're thinking about strategy, you need to think about the arterial monitoring first. So you want left and right arch monitoring. So you'd probably want right radial and femoral monitoring. If you do go through the femoral artery cannulation strategy, which no one mentioned here, which is still a viable and very safe option, then you'd probably want the anesthetist to place their monitoring line in the opposite side when this has been planned. So think about the cardiopulmonary bypass setup, the venting strategies such as right superior pulmonary vein vent or an LV apical vent, if you prefer that. You need to think about your myocardial protection, cerebral protection, whether this is retrograde, antegrade, unilateral, as some people have mentioned, or whether this is going to be selective. And how deep you want to cool the patient. And this has been highlighted in the previous talks we've heard before. So cannulation, I think, can be broken down into two principles, central and peripheral. And the guys coming up to the exam or trying to adopt an examination technique probably should just branch it into these two broad categories. And within these two categories, there are several options. So if you're talking about the central option, there is ascending aorta. There's the arch you can cannulate. You can cannulate the innominate artery within the chest with a high flow angle cannula, which gives you a little bit of manipulation with the direction you can point the high flow cannula to. There is very, very rarely the option of an LV apex cannulation strategy, which I've not seen, but it has been done. And within that, there is direct cannulation. So what I mean by this is where you have identified, based on your review of the CT scan, a safe position on the ascending or arch or innominate, an area that is not dissected, an area that you know is the true lumen, where you can directly cannulate this using your standard techniques. The second is via Seldinger, which we've discussed. So the Seldinger is using a large bore needle where you would enter or aim to enter the true lumen. This could be via the false lumen, where you would first enter the false lumen, then you would hit the membrane, and then enter the true lumen. So this is a very subtle feature. And again, if you don't have the experience doing it, it can be very subtle and difficult to identify. But you do have the option of TOE guidance, where you would pass a wire under TOE guidance, and between you and the anesthetist, identify the true lumen and establish that you're certainly within that before you pass your cannula. Peripherally, which I think is more straightforward, you have the options of femoral, you have the option of subclavian auxiliary, and you also have the option of carotid, again, probably the left carotid in that instance. So these are your broad categories for cannulation. Central cannulation depends, as I mentioned, the extent of your dissection, whether it's a DeBakey 1 or DeBakey 2. You have the high ascending aorta or arch with your standard purse string and standard cannulation. The uncertainty comes about regarding where your false lumen is. You have your innominate artery, you have your Seldinger, we've discussed this briefly, and then your direct aortic. So there is a samurai technique which Yasir described, where you would need to drain the patient, open the aorta, identify your true lumen, and pass your cannula into the aorta. But then you'd need a tape around it, and you'd need to have that secure enough so that you don't have any continuous leak once you've re-established perfusion. There's the modified samurai technique, which employs the same principle of identifying the true lumen. However, you're passing either a needle via the ascending aorta, you're identifying that the needle is going through the membrane or the dissection flap into the true lumen, and then you pass your cannula over it, over a guide wire. And the advantage of this is that you don't have to tape your aorta, and you can quite easily clamp below it. Whereas the traditional samurai would not allow you to clamp below the aorta so that you can attend to the root. At that time, you will have a cannula sticking out of the aorta and may get in the way. Venous, again, there's two options, central and peripheral. Central is right atrial drainage, which in most dissections you can establish if you can enter the chest safely. And there's the option of bicaval cannulation if venous drainage becomes inadequate with just a 2-stage. And then peripheral is either femoral, which you start with, and depending on the case, sometimes you might run into trouble with inadequate venous drainage and have a low threshold for swapping over to central drainage if that were the case, rather than struggling on bypass with inadequate drainage. So that's essentially what I had to say. Thank you for the engagement of the candidates. I'm happy to answer any questions or review the case again.
Thank you. I think actually we're going to go to Professor Redmond's case. Mark, is that okay with you? Debs has already had the floor, so we'll keep her in reserve. We've got about 30 more minutes. And while you're getting your technology sorted out, that was a great case. Thank you for bringing that. I think for the trainees, if you've got that case as a first aid consultant, get help. Don't try and struggle that in your first on call as a consultant. I think that's quite a complicated case, and it will need help. So Mark, thank you so much. Nice to see you virtually again.
Good.
So the floor is yours.
Great. Everybody can hear me, I assume. Malcolm, can you hear me?
Yes, we can hear.
Great.
We can see.
Super. Sorry, I'm zooming in from France, so technology is not everything I normally have at home.
Ah, bonjour.
There you go. So I have actually two cases to present, so I'll be a little bit faster in ensuring that we can discuss both, and you'll see why I wanted to do two cases. So they're both redo thoracic aortic cases. And this is the first case, which is that of a 46-year-old hypertensive male. Now, he had a repair of an acute type A dissection in 2007 by another surgeon, and was referred to me then subsequently by that surgeon. This patient recently had developed symptoms of chest and back pain, and his scan, I'll run it here. I'm controlling it just to make sure that everybody can see the aortic arch. And as you come down, there's the ascending aorta. Keep an eye on that. And you'll notice there is an odd looking portion to the ascending aorta. Keep an eye on the descending aorta. While I'm finishing these, Malcolm, is there any way you want to pick one person to comment on what they've seen?
Yes. Have we got Jason Lungin? Jason, do you want to unmute and have a go?
Oh, yes. So
Jason, just before you comment, I want you to keep an eye on what you're seeing. Okay. And then let that one run, and then take a look at the next other view, which I think will help as well. Okay. So tell me what you think you've seen so far. Okay, Jason?
Sorry, can I get one more run of the axial views?
I'll speed it up a little bit for you. Now you notice that's the distal ascending aorta, isn't it? And what I want you to focus on is that. and the descending aorta also. So any thoughts?
So it looks like there's a dissection at the arch of the aorta, as well as an intramural hematoma descending aorta. Yes.
Okay, I'd agree. So what is important is the fact that I want you to comment more specifically on the ascending aorta. So we see what do you see there in the ascending aorta? You can see the three sinuses. The aortic valve, you agree?
Yes.
And as we go up, what do you think that is?
I think that's a dissection at the ascending as well.
Yeah, actually what it is a pseudoaneurysm above the interposition tube graft. See, there's the tube graft. And as we head up, you see that. So it turned out to be a pseudoaneurysm. Okay, so that's number one. And then you correctly identified the residual chronic type A dissection with the aneurysmal dilatation. The true lumen is very squashed there, isn't it? Now, in terms of what we're going to do for this gentleman, what do you think about the distal portion of the descending thoracic aorta? There. Is there any dissection there?
I don't see a dissection plot.
Yeah, I agree. So that's my point. So in some respects, it's a little more unusual in the fact that if you see here, the descending aorta, the dissection ends really at the level of the diaphragm. So that gives us a few options because this is a redo operation. And the point is this gentleman is 130 kilos and he suffered the sequelae of a long operation from his original operation, had moderate LV dysfunction and had a mild to moderate aortic incompetence. So the choices are, and I'll just go ahead and state them, either two-stage elephant trunk procedure, but there is also an option for a frozen elephant trunk with a TVAR completion. Now, Malcolm, I don't know if you want to ask anybody, have they want to comment to choose one or the other?
Okay, Lowe, are you in? If you want to unmute and make a choice with your recommendations.
I would choose to do a frozen elephant trunk with a TVAR completion.
Yeah, so the latter of the two you would choose. So without further ado, I'll move the case along. So yes, I'd agree. We chose to go with a frozen elephant trunk procedure with TVAR completion at the same sitting. And here, my preference is the Thoraflex. I'm sure most of you will recognize that there's the Evita. There are others. I just happen to like the Sienna color on these grafts, and I like the feel of the graft overall. As we'll come to the intraoperative deployment, perhaps. So what therefore is our pre-op strategy, our perioperative strategy? Of course, multi-slice CT scanning is mandatory. And the only reason I mention it here is that some patients will come having had an MRI showing some aortic pathology. I would still repeat scanning with a multi-slice CT to help plan surgery. We need the operative notes, of course, from the previous surgery. And in many of these patients, particularly those who've had previous bypasses, we would absolutely require coronary artery imaging. Intraoperative monitoring is very important with bilateral radial arc lines plus or minus femoral arc line, bilateral NIRS, the transesophageal echo. Of course, that's going to be important for positioning of the femoral venous cannulae. also to prove we've got good cardiac decompression during cardiopulmonary bypass to tell us if we need a vent earlier than is normal. For this frozen elephant trunk procedure, because we were doing a TVAR completion, we elected to place a spinal drain. Now, we did not perform somatosensory evoked potentials, which you could argue may be useful. The reason is that I would do this at the second stage of an elephant trunk procedure when we're reimplanting spinal arteries. But in terms of this operation, we are completely covering all the spinal branches up to down as far as the diaphragm. So I don't feel it important to do somatoevoked potentials during this redo surgery, but definitely would use a spinal drain. Malcolm, could you ask anybody to comment on what they think a normal pressure for a spinal drain is and when one should start opening the drain to drain some CSF fluid?
Saravanathan Sajiram, would you like to comment? You can unmute yourself. Or Royan Richards. Royan, are you in?
I don't want to waste too much time. So maybe make the comment that usually if it's 15 centimeters of water or lower, we're pretty happy. Above that, we would be inclined to drain CSF during the case, or particularly in the first 48 hours post repair. So the most important question I think I'd like to ask is, should we initiate, when to initiate extracorporeal circulation before the sternotomy? And this is important because the mortality following aortic sternal re-entry injury with catastrophic hemorrhage is 47%. So if you hit the aorta and get catastrophic bleeding, no matter what you do for the rest of the case, you've now got a 50-50 chance of getting that patient home. So you don't want to make a mistake of not having prepared for extracorporeal circulation before your re-sternotomy is complete. So I throw in these here just to help. We should strongly consider ECC before the sternotomy if the aorta is obviously very close to the inner table of the sternum. If we were to, for example, start the dissection at the lower end at the Ziphy sternum and find the heart is just particularly stuck, maybe there was a history of mediastinitis from the previous surgery, then that might be a time to step back and institute extracorporeal circulation. An important one is if the patient has functional tricuspid regurgitation. That tells me the RV is going to be very distended, stuck to the back of the sternum. And also the right atrium is going to be distended. And if we hit the right atrium, it's going to be a problem. Of course, if the patient were to get hemodynamically unstable or have electrical instability, that might be a reason for ECC before this full sternotomy. And for those patients who have significant LV dysfunction, they won't tolerate much here, even during the dissection. So I would tend to be liberal with the employment of extracorporeal circulation. Now, there are many options, and we've heard very elegantly from the previous talk, ways to cannulate. But to mention that there's central arterial and venous cannulation is if it's going to be straightforward and the adhesions are not particularly troublesome, that's clearly the best way to go. My preference, and what we chose here, was a right axillary arterial cannulation with an 8mm Dacron tube graft, as you can see, and there are names of the nerves we had to watch during the dissection there. And that obviously is very useful because it aids with antegrade and indeed ultimately selective cerebral perfusion, but has the disadvantage of having to heparinize to some extent prior to the sternotomy. Direct femoral arterial cannulation could be done, in this case, because if you remember on the CT, there was no dissection beyond the descending aorta, and the multi-slice pre-op CT imaged the femoral vessels all the way into the lower extremities, and that's important to have established that knowledge prior to a redo operation. And then finally, multi-stage femoral venous cannulation could be done electively or with vac assist, particularly if we create a defect somewhere on the right side of the heart. So assuming that we cannulated, as we did here, the axillary artery arterially, and we actually had some degree of hemodynamic instability. Remember, this patient had LV dysfunction, and we ended up going on bypass before the sternotomy was complete and the dissection complete. So we used a multi-stage femoral venous cannula. And we also did require a left atrial venting, and I'll come to that shortly. But what is our strategy? And every one of you needs a strategy for a great vessel injury or cardiac injury during resternotomy. And here I've tried to allude to some of the things that I'd like you to think about. Above all, if we have an injury, stop the resternotomy. Do not attempt persisting to achieve control. The temptation is to just open up a little bit more. Maybe I can control the bleeding. And I've learned, and as I'm sure many others from bitter experience, that's not a good idea. So as a surgeon, if you make a mistake, the only way to atone for that mistake is to make sure nobody else makes it. And so I would strongly recommend stopping and concentrate your efforts on reapproximating the sternal edges tightly with penetrating towel clips, and one of the assistants also applying extra compression if necessary. And now institute a blood transfusion protocol with anesthesia and aim for direct femoral arterial cannulation, as it's probably the quickest. Multi-stage venous cannulation with a stiff guide wire to make sure it goes in with TOE guidance is important. We will initiate cardiopulmonary bypass, and vac assist not only helps decompress the heart, because we've no vent at this stage in the LA, but it also is very helpful for one of the more common injuries, which is to end up with an open innominate or a torn right atrium, and we are entraining air, and we'll end up with airlocks if we don't have vac assist. And we would initially cool for HCA, especially say for an aortic injury, but we have the option to, if the bleeding is now controlled, to halt the cooling and get back to a more stable situation and not necessarily circ arrest, to complete the dissection rather on full bypass, and knowing that we'll avoid the ventricular fibrillation if we don't cool beyond, say, 25 degrees. So in our patient, we did indeed require a left atrial vent through a left anterior thoracotomy because the patient got a little unstable hemodynamically, and we went on ECC like I mentioned, and because he had aortic incompetence, you remember we said he had mild to moderate aortic incompetence and LV dysfunction, we electively performed a left anterior thoracotomy even before we had completed the dissection. And that brings me to the next point. The most important aspect of these redo operations is, one, to protect the brain, of course, but most importantly, as a cardiac surgeon, we're here to protect the heart. So we'll avoid LV distension after the initiation of ECC, like I mentioned, with a vent, and we need the appropriate strategy for cardioplegia. So once we are in and fully dissected, that's the time to think about cardioplegia retrograde in the presence of aortic incompetence, as with this patient, followed by direct antegrade cardioplegia when the root is open. Now, there are 2 or 3 issues to highlight. In our patient, we were able to do a sinotubular reconstruction of the normal trileaflet valve because, as we saw from the studies, his sinuses were normal in terms of aortic diameter. We then did the frozen elephant trunk as per usual, and we'll take a look at the results in a moment. But there are 2 important Cabral modifications to keep in mind. Were we to do the aortic root, Standard buttons are fine for first-time surgery, but mobilization of coronary buttons after previous aortic root surgery is not as straightforward. And in these cases, the Cabral modification, which is to introduce either a prosthetic or it could be saphenous vein to do the coronary button anastomoses, if you want, and prevent either kinking, or if mobilization is difficult, to provide extra length, is important and should be used to avoid coronary ischemia when the clamp comes off. Now here you've seen two, for the left and the right, two short segments of, it could be Dacron or Gore-Tex graft. And as in the Cabral's original description, we could have the left graft coming around the back and implanted either directly into the side of the ascending graft or indeed into the right-sided graft. Cabral, finally, pericardial patching can be used simply to avoid a kink. And again, bleeding, of course, is an issue in these situations with lots of suture lines, but it is another option. The final one, which we've talked about in previous review courses, is the use of a Cabral patch, where we sew usually a bovine pericardial patch to the great vessels and to the cardiac structures for excessive bleeding, which is resistant to blood products. The advantage of this, of course, is that it will let you get the patient out of theatre and fully resuscitate, and eventually is a way of saving a patient's life for when we have life-threatening bleeding. Sometimes, however, the patch itself is, which we sew on here, has to have access to the right atrium, and we can either release the right atrial appendage purse string after we've sewn the patch on, and therefore we have an opening directly from the space into the right atrium, or indeed do that with the innominate vein, or indeed we can sew a graft, as in Cabral's original description, from the patch into the venous system at some point. And here's an interesting way of doing it using a valved conduit, a contigra, which was described by Eleftheriades in an interesting modification of the Cabral patch. So what did we end up with? Well, here we see the patient. You'll notice it's still intubated, so this was an early scan done on post-update 2. And if you look correctly, you can see our frozen elephant trunk area there. We're free of any endo leaks. And you'll notice now the ascending aortic portion and head vessels came off there okay. There's the TVAR completion going through the chronic dissection and aneurysm, and then making its way down to the supraceliac aorta at the level of the diaphragm, and we have a nice completion. And to show that on this view here, you can see there's the ascending graft, a little bit of a minor kink into the thoraflex with the head vessels coming off. And then there's the site of the TVAR. You can now see we have actually used 3 separate grafts. We used 2 to reach the descending aorta, and we had a small endo leak in the middle between the 2, where the 2 overlapped, and we used a 3rd graft. So I might, if I may, Malcolm, if I have time, just to have a slight change in terms of the redo. And this time is a 28-year-old young man with bicuspid aortopathy. Okay, now keep in mind this gentleman had an aortic coarctation repair at the age of 3 using a polygraph patch. And I'll move it along.
So Mark, we've got about 10 minutes or so,
Yeah.
which I'm sure is absolutely fine, but that's just to give you an indicator as to where
Perfect. Yeah, sounds good. I won't spend too much time because it does slow us down when we have a lot of commenting, trying to find people, but I'm going to ask you to pick one person to tell me what they see here, Malcolm, if you don't mind.
Is David Bleetman in? Do you want to unmute David?
Yep, I'm in.
Thank you very much.
So I'm just getting a handle on the pictures. So again, we've got an axial CT, slides with contrast. Main abnormality is gross aneurysmal portion of the, looks like the distal arch and the descending, with appears to be a filling defect in the descending as well. Not sure if that's a
so
a flat or a pseudoaneurysm.
Yeah, so it's exactly right. So it's a pseudoaneurysm of the patched onlay patch that was used for this patient who underwent coarctation repair at the age of 3. And in those days, it wasn't unusual to use patches. We never use them anymore, but they were used. And the reasons they're never used anymore is what you're seeing here, the almost inevitable pseudoaneurysm formation in these patches. Okay, could you comment on the arch for me? The proximal arch.
Yeah, so it looks narrowed or compressed, doesn't it?
Okay, you might say narrowed or compressed, but the key in is bicuspid aortopathy with these patients inevitably have a hypoplastic aortic arch. And nowadays, when we fix these, of course, we do an extended end-to-end arch aortoplasty as a neonate, so we don't have a small arch anymore after aneurysm repair. But in, older patients in congenital heart surgery and adult congenital will have that problem. And I'll explain why that's important shortly. This patient did undergo attempted device occlusion. And you can see the device there, the odd-looking piece of equipment there posteriorly. And that, of course, didn't help because 11 years later, we're left with this massive aneurysm. Okay, so the choice is for repair. Do we go anterior via a first-time sternotomy, even though it's redo surgery, or do we redo thoracotomy? And before I ask Malcolm to pick somebody to answer that, in terms of the repair, we'll just run this, and I think you get a sense of the arch and the pseudoaneurysm. And you can even see the device that was used to try to repair this in the past. Okay, so Malcolm, maybe somebody might explain to us how they might try to approach a repair here.
David, would you mind if we stuck with you just in the interests of time? You seem to be quite experienced.
Yeah, right. Okay. So, I mean, the priority here is to I mean, if you're doing the full assessment, the root and the ascending and at least the proximal arch look reasonable, but then at the area of the left subclavian, you've got the narrowing followed by the aneurysm. So you'd want to intervene on the arch at that point and establish continuity with the descending while excluding the aneurysm. So I'm not sure whether you do a redo thoracotomy. It'd probably make more sense to do a sternotomy, I would imagine, and then use a frozen elephant trunk to establish continuity would be my sort of limited approach. Yeah.
Of course, I wanted to set a trap. The problem, if you think about it, because we all think frozen elephant trunk, we're all thinking especially redo surgery from the front. Unfortunately, sometimes they're not going to get us out of difficulty, because if we try to squeeze some kind of frozen elephant trunk graft in there, we're going to be left with a serious arch problem. So then you'd be thinking maybe debranching, maybe something along those lines. And of course, this is a young patient. He's 28 years of age. I don't personally think that would be very appropriate. But it's this, if you look, it's almost like a bovine arch, isn't it? And so how do we overcome? So we elected anyway for a redo thoracotomy. Okay, and what I want to do is very briefly discuss that. There are certain considerations for such patients. And the reason we tend to do it is maybe because I'm a congenital surgeon too, that you can get quite used to augmenting the aortic arch from the side. And so that's what we elected to do for this patient. There are two things to keep in mind. They need patients in redo thoracotomy settings. We very much need some form of extracorporeal circulatory support. And the options are obviously a full cardiopulmonary bypass with the reservoir, the pump, the heat exchanger, all very useful, but because we're using the oxygenator and the reservoir, we need to be fully heparinized. So that's a potential downside. We can use pure LAFA bypass, but now we can't control temperature. And if there's something goes wrong during the case in a redo setting, or something goes wrong with the arch portion of the surgery, we suddenly needed circ arrest, we clearly have no control. So in these scenarios, in redo thoracotomy settings for redo distal aortic arch surgery, I'd strongly recommend full cardiopulmonary bypass setup by cannulating the not necessarily left atrial appendage. The best place to cannulate is one of the pulmonary veins, usually the inferior or middle pulmonary vein, as that remains outside the pericardium. Inside the pericardium, you have run the risk of some oozing or bleeding and a pericardial tamponade, whereas we don't want to get into the pericardium at all when we're doing these redo operations. So we can justify the full cardiopulmonary bypass, in my opinion, for redo cases. Clamp and go, not appropriate. So which intercostal space for this patient? Well, to speed things along, the fourth intercostal space is what we chose, with notching of the third rib. In redo settings for these surgeries, we've got to preserve the recurrent laryngeal nerve, the phrenic nerve, vagus nerve itself. Spinal cord protection is less of an issue for us because we are mildly hypothermic, which provides a very good protection for the spinal cord. You don't need deep spinal temperatures to get spinal cord protection. But we're already using distal perfusion because in this case, we put the arterial cannula actually into the descending aorta. We didn't need to go into the femoral vessel. But importantly, and I want to emphasize, the esophagus is in play here. With a difficult dissection, it's easy to injure the esophagus. So here's our intraoperative specimen. So we did manage to, here's the descending aorta normal. This is the pseudoaneurysm, and there's the device that we used to plug it off, and that was the finished product when we put in an interposition at 20 millimeter Dacron tube. But the important thing to remember is we spent a lot of time dissecting, probably well over 60 minutes dissecting the lung off and making sure we preserved all the nerves. And in this post-op imaging, we can see that we managed to, as you can see, augment somewhat the ascending aorta because we used a beveled tube. And we can run the scan here to show that the hypoplastic aortic arch has been appropriately enlarged. So I only present this case really to highlight the fact that not everything can be done with a frozen elephant trunk procedure and from the front, that sometimes redo aortic arch or descending thoracic aortic surgery should be done appropriately from the side. So we could take some questions. I put in that handshake because I can't remember quite what that is anymore with COVID, but maybe one day we'll get back to that.
So Mark, maybe one question to follow up on, and then I'll hand over to Aaron. Somebody's made the suggestion, what about an ascending to descending bypass and then ligate and exclude the aneurysm?
That was discussed with this patient as well, the so-called Cooley graft, Malcolm. So I think that wouldn't be unreasonable as an option if this patient were particularly high risk, if they were, say, much older. But experience with the Cooley graft in young patients, and there is plenty of experience because for patients with, say, severe complex Schoen syndrome, where they have a lot of obstructive problems from the left side of the heart, from the subvalvular all the way to the distal arch, these Cooley grafts were used, but they have their own problems, particularly in relation to the anastomosis in the posterior mediastinum. But it would be a bailout, of course, I think, were this patient high risk. But as for a long-term solution for a patient like this, I don't think it is a good idea myself.
Great, thank you. Thank you for the cases. I think there's some really good learning points in those cases for trainees at all of the relevant stages. That there has been some conversations in the chat, and I'll just emphasize again that you've got very high-grade aortic surgeons presenting very complex cases. Quite often you need to adapt this to the environment that you're working in, and if you're presented with these cases, then please get help from someone like Mark to figure your way through it. But I think some of the principles are perfect. So maybe with that, Aaron, I can hand over to you to close off the session.
Malcolm, thanks very much. I can't believe that we've almost run to time. It's amazing. I'd like to thank everyone for participating. Duke for getting up in an ungodly hour, and Pedro as well. No, Pedro, you're probably okay, I think. You're younger as well. Mark, thanks very much for joining us from France. Debbie, thank you. Eshan, I know you've been up all night as well. So thank you very much to everyone for joining in. Thanks for the discussions. That's the end of the cardiac section of the review course. You've got one more session left to survive. So in 30 minutes, you're back on with the thoracic surgeons. So I hope you enjoy that session. Once again, thank you to CTSNet for the live streaming. And I hope to see a lot of you next year.
Thanks, guys. Bye.
Thank you very much.
Bye. Thank you.
Bye now.
Thank you.